Hello, everyone, and welcome to the Center for Health Design's Evidence-Based Design Journal Club. Thanks for joining us. I'm Alan Card. I'm a research associate with the Center for Health Design, and I'll be your host for today's session. Before we begin, I'd like to thank the Health Environments Research and Design Journal for providing free access to the articles we typically review. If you've not already done so, we recommend subscribing to HERD. There's a discount code for attendees to receive 10% off the subscription using code HERD10. The purpose of the Evidence-Based Design Journal Club is to engage the healthcare design community in dialogue regarding important research and to help us better understand the links between the built environment and health-related outcomes and apply those to the real world. Continuing education units are available for this webinar from the AIA and from EDAC. To receive credit for your participation, you can download the forms at any time by clicking on the Show My Media Library icon, which is located on the top toolbar where the red arrow is pointing. You'll have access to the AIA quiz, the EDAC form, and today's presentation slides. To download a file, click on the green arrow next to the file. When you're finished, click on the double right arrow in the top left corner of the media library. The library will close, and the slides will refill the empty space. For EDAC credit, complete the verification form and retain it in your records. You'll need to submit the form to Castle Worldwide at the time of your renewal. For AIA credit, complete the verification quiz, purchase a CEU management fee for $10 from the Center for Health Design store, and submit the verification form to Catherine Anchetta. She'll upload the credits to your AIA account. You'll find Catherine's email address included on the form. I'd like to take a moment now to review how to use the chat feature so that you can ask questions or submit comments on what you hear today. As shown on this slide, just type into the chat box where the red arrow is pointing. Please be sure to chat your questions to all so that all attendees on today's call are able to see your message. If you're having any technical difficulties, please type your issues to moderator in a private conversation, and we'll see how we can help. I'd now like to introduce you to the authors of the article we're discussing today, Emily Patterson and Steve Lavender. Dr. Emily Patterson is an associate professor in the Division of Health Information Management and Systems, School of Health and Rehabilitation Sciences, College of Medicine at The Ohio State University. She has a PhD in Industrial and Systems Engineering from Ohio State University. Dr. Patterson applies human factors engineering to improve patient safety and quality in healthcare. Her research focus areas include communication during transitions of care and health informatics. Steve Lavender is an associate professor in integrated systems engineering and orthopedics at The Ohio State University. His research focuses on the development and evaluation of ergonomic improvements to work processes. Recent projects include the design of med-surg patient rooms to meet the needs of all occupants that work in med-surg rooms, the development of ergonomic interventions for patient handling tasks performed by EMS responders, developing ergonomic interventions for imaging technologists, biomechanical evaluations of emergency evacuation devices used in high-rise buildings, assessing the efficacy of interventions aimed at lower extremity discomfort in distribution centers, and investigations into the factors that affect the adoption of ergonomic interventions. Thanks very much to both of you for joining us today.
Thank you.
As I mentioned, we are hosting this event to identify the everyday practical applications of research findings in a published article. Today's featured article is Meeting Patient Expectations During Hospitalization, a grounded theoretical analysis of patient-centered room elements from the Health Environments Research and Design Journal. On today's call, we'll have an active discussion, including you, our listeners, about different key factors in your study. And without further ado, I will turn it over to our authors. Thank you.
Well, good afternoon. I'll start off, I guess. So let's see. Well, let's talk about patient rooms. And we're particularly interested in med-surg patient rooms. Let's face it, there's millions of overnight stays in patient rooms. There's lots and lots of people who come in as visitors and caregivers that support those patients. We know that patient satisfaction is important because that's going to affect the reputation of the facility. It's going to affect reimbursement. But, one of the key things we're looking at is there's a trend as we move forward. In fact, Ellen Taylor talked about this at the recent Healthcare Design Conference of, moving towards single patient rooms. And that was really our focus. We were also considering acuity adaptable rooms, but, keeping in mind that as we start to build these new rooms and as we remodel rooms, that there's more of a presence of the family than before, and we want to take that into account as we think about the needs of patients and their visitors. Today, we're primarily focused on the patients, but I want to put this research in context. This was part of a much larger study that was really aimed at addressing some of the issues that some of our occupational stakeholders were having working in patient rooms. We see patient rooms as a workplace, and as such, what we're trying to do is design that workplace so that it works for all the different folks who work in that space. And, to do this, we started out, we did a 4-phase study, as you can see on the slide. We started out with some focus groups and interviews of all the stakeholders, our occupational stakeholders, and as well as patients and visitors. But we started out with, how do room parameters or room design features facilitate or interfere with what you do within that room, within that space? Then considered, what would it be like if you could pick or design the space you wanted to work in? And so that was the second phase, and I'll talk about that in just a minute. And then we got into our third phase where, let's face it, if we get it right for the occupational stakeholders, we still need to get it right for the patients and the visitors. And we needed to check in with them and find out just what are their needs, what are their expectations, and that's largely what we're talking about today. And of course, there might have been some conflicts, which then we went on to address. And the ultimate goal of this project was to develop guidelines for architects and interior designers regarding these spaces, med-surg rooms in particular. And in fact, we presented our first version of that at the most recent Healthcare Design Conference. All right, so when we started talking to occupational stakeholder groups in that first phase, we started digging into this, and we found out, we came across 23 different stakeholder groups across our 146 participants in our focus groups and interviews. And there could even be more that we didn't include. For example, the clergy aren't represented here. But these were the primary groups that were doing activities within the rooms on a regular basis. And their needs all differ for, what they need to be able to do in that space. And again, what we're trying to do is understand what their issues were. In fact, when we ran these focus groups and interviews and we broke down the data, and this is described in our HERD publication, what we did was we broke it down by, what are their issues as they enter the room, what are their issues as they prepare to do what they need to do in the room, what are their issues as they do what they came in to do, and, what are their issues on exiting. And, here's the doing phase, and we just took all their comments and we put it into a Wordle, and, you could see that there's some key words that jump out at you here. Inadequate, space, difficult, need, lack of, all that kind of stuff. So that set us up for our second phase of this work, where we asked participants to come in and as a group, and these were mixed occupational groups. We had 104 people. We asked them to design the room or make a room that they want to work in. It was they were put into a room which was a 300 square foot space, 15 feet by 10, that had essentially movable bathroom walls. And if my cursor is working right, you can see this little stand here. That's actually a bathroom wall. Here's a guy pushing a toilet around to where he thinks it should be. But these were groups that ranged anywhere pretty much from 3 to 7 people working on designing these spaces. And, they would come into that space. There were, the bed was in there. There was a couch in there to represent a sleeper sofa for the family zone. Everything was on wheels that could be moved around, the movable bathroom walls. And over about 45 to 60 minutes, that group would then position things, and then all the other things that are in a patient room, all the sinks, the horizontal surfaces, everything else was brought into the room, and they had to start figuring out where it all went. And then, which was an interesting process. And, based on that, we ran 27 groups. Of course, we got 27 designs that we then were able to cluster and reduce down to 5 what we call hybrid designs, which became the stimulus for this third phase, or where our objective was then to identify the patient needs and expectations that can be utilized to inform design or renovation in these med-surg patient rooms. And so, why should we do this? Well, here's our multiple choice question, our first question for you of the day. We'll give you just a second to indicate an answer. Okay, it's not that hard, really. Okay, so hopefully you're seeing that survey question. And, yep. Oh, we're getting our poll in right now. And there you go. Looks like all of the above is winning. Excellent. That's the right answer. All right. Can we go back to our slides now? All right. So, what we did with our patients was we brought them in, and we had 15 sessions with former patients and family caregivers. And, there were 37 patients that participated. Our filtering rule there was that you had to have a 3-day minimum stay within the last 12 months. If you look at the age distribution, not a big surprise. Most of our patients were over 45 years old, but we did have a few younger folks in the 30 to 45 range and one person under 30. But we also had 24 family caregivers that participated as well. But as I said, today the data that we're talking about is focused on what we learned from the patients in this process. So what they did, as I said, we came up with 5 hybrid room prototypes, and we showed those to our patients as they came in for these sessions. They got to see 2 of the 5 rooms. There wasn't time to take them through all of them. And, they would be exposed to those rooms. I'll show you what they look like here on the next slide. For example, what you're seeing is a layout diagram of one of the first room of the 5, just to get you oriented. The door is over here on the left side. The window's over here on the right side. You can see the bed. There's a bathroom down here. In this case, there's a outboard bathroom with a sliding barn door. Likewise, there was a sliding room door here with a separate breakaway door if they needed additional access. But the idea was then the door didn't swing in and take up space within the room. And what you could see in these photos, I'll admit they're not the best, but what you can see in these photos is this is the level of the mock-up that we were using. It was full scale, and what you see is we had Velcro on all the walls so that things like, here's the paper towel dispenser, here's the sharps container, the gloves, all that stuff they could put wherever they wanted. They just stick it on the wall, and there it is. Obviously, in most cases, there was plenty of discussion about where that stuff went. But, once they, and it didn't always stay where they first put it. Things did move around until we got to the end, and then everybody in that group was happy with what they had. You know, some key features in this room that you're looking at, you know, we have the family zone out here on the outside. There is a privacy curtain here between the family zone and the patient bed. There's another privacy curtain over near the door. And then there's a large surface over here near the door for staff to set up and do whatever they needed to do. Here's the second room that some of these patients toured, and inboard bathroom. What really jumps out here is the bed is angled. Well, that facilitates views out the window. One of the things with this bathroom is this one had a hinge door as opposed to a sliding door. But one of the other features in this room is that instead of having a head wall, all that stuff was put on a boom, so that could be swung out of the way. It could be moved depending if it was needed. But it also gave caregivers access to the head of the bed, which they talked about as being important under, certain conditions. The third room, what you see is, we have this center door, again, outboard bathrooms with a sliding door, barn-style door. The bed is, located on the inboard half of the room. But one of the key things in this room was the family nook, as it was termed. This little area out here that was designed for the family to be there and hang out for perhaps extended periods. And then, likewise, there was a lot of horizontal surface in this room, as you can see by this yellow in the slide. That's all horizontal surface that was available for staff, and to some instances, this could be used by patients as well to put some of their things. So that was considered extremely valuable there. The fourth room, this is more of our, kind of the standard room as it was referred to. Basically, inboard bathroom with a hinged door. Again, an angled door, such that would, facilitate patient views from the corridor. But it also had a full window on the side over here. And what you could see is that, the staff work area was over here near the entry. And then as far as the fifth room goes, again, inboard bathroom, sliding door in this case, and, again, a barn-style door. We know we can't do pocket doors. Epidemiology gets nervous about that. But you'll notice that the key thing here is the bed is in line with the door. And, I will say that was a popular design with some of the nursing staff who wanted to be able to look in and assess the patient quickly from the corridor. So, that's kind of where that came from. But you can see there's lots of open area there around the foot of the bed and at the family zone, which could be really nice in a teaching hospital kind of environment. Okay, Emily, I'll turn it over to you, and you can talk about our data collection process for the patients and what did we learn.
Thank you, Steve. So, as Steve mentioned, this is part of a larger project. This part of the project focused on patients and their family caregivers. So we were specifically looking at somebody who is in charge, if you will, of the care of the patient as well as the patient. So we had a recruitment process where we collected together groups at a time of patients and their caregivers when we could get both, or else just patients if we couldn't get both. And we showed them two of these rooms that Steve just went through. We had them complete a survey when they're in the room about the specific parts of the room they liked and disliked, came back and talked about that in a round robin. What did you like? What did you dislike? As well as in general, what was important to them in the room. So obviously we added up all the survey data responses and looked to see what was most important to them. but probably much more of our time, much more of our effort was focused on a bottom-up qualitative thematic analysis. So we did a process called memoing where we looked at the transcripts from each of these sessions and came up with themes that emerged about what it is that patients really wanted and needed in a room that was supportive for their needs. And then a big part of that was we had a lot of people with very different perspectives. We had a design perspective, engineering perspective, physical ergonomics, and cognitive, thinking about what is it that people need from a patient safety perspective, a falls perspective, and then informatics expertise all represented on this team. And so a lot of the value came in working out how we saw the data differently. So, drum roll, please. Here are some representative quotes of some of the things that rose to the top. So one thing is our survey data showed a polarization or a mixed response on whether or not patients wanted to see from the bed out to the hallway. But one of the things that was very clear is that patients did not want to be seen from the hallway unless they decided they wanted that. So they wanted control over that, and they wanted, particularly like if they're on the bedside commode or something like that, they really didn't want to be seen from the hallway. And so that was one element of what they were looking for. Control rose to the very top as the top priority, which surprised us a little bit, as the top priority of the patients and family caregivers. So they wanted control, not just of the lighting and TV, which is what we sort of started our thinking with, but also the blinds, the temperature settings in the room. They essentially wanted everything controlled from the bed or the recliner on the way we designed it was a universal remote. And then they wanted the shortest, there's variations on shortest possible distance. Basically, they wanted to go from the bed to the bathroom day and night as quickly and easily as possible. That included not having to walk backwards to open the door. That included having an IV pole or other things attached to them. So the paper has a long list of things that people want organized. We just picked out the top ones. So obviously space matters. Obviously having it be comforting to them mattered. They wanted easy access to the bathroom day and night. That included things about night lights and how to get there. And also not having heavy doors that they had to open. They wanted to see who was coming into their room and whether or not they were washing their hands at the staff sink. They wanted easy access to power, information, entertainment types of things, control over their visual privacy, so not being seen from the hallway, and then the noise, environment, and electronics, so control. And they wanted an organized place to put everything. And then they wanted these eye-level conversations with clinical staff where it wasn't heard from the hallway. So we pulled this all together and said what actually was, if you will, the center of what they're asking for in supportive room design from a patient perspective, and it's comfort. And what rose to the absolute top is this sense of privacy, of not being sort of institutionalized in some way. They wanted privacy and security in the room design. And then what enabled that was a sense of connection. So the family was the first sense of connection. They wanted to be able to display cards and gifts and photos of family members and have family members close to them in the room. And then they wanted home-like things. So they wanted to bring in their Bibles and display that. They wanted connections to the outside world, which included a large window to look outside and see nature, or it also included pictures of nature and things like that. Access was primarily about access in the in-bed environment early in the hospital stay, being able to reach all of your hot and cold drinks, your glasses, your cell phone, your lip balm, without having things fall off that's hard to get to, and then having a garbage can that's near the bed so that if you blow your nose, you can throw out the tissue while you're in bed, that sort of thing. And then I've already talked about sort of control over the connection between the bed and the recliner in the hallway. So patients wanted to have these four things, and I'd like you to just take a look at this and think about this in contrast to the HCAHPS scores. So we went back to the patient satisfaction survey, and there's 18 questions that we think relate to 13 of 18 questions that we think relate to patient satisfaction with the research that we did, but none of them really get at these 4 things directly as far as we can tell. So we're suggesting that these 4 things might be something that could be measured and improved upon from the perspective of supportive room design. Now, the thing that we were told is you want to know, okay, so what do we do with design? So there's not a checklist of 6 things. We decided to leave it at what it meant from the patient's perspective, what it meant to build empathy. But just as a few examples, personal space and safety, you could have a dedicated tray table for the patient. You can have a dedicated small table for caregivers in the room that staff don't use. So that way their personal space and safety are not infringed upon, if you will, by staff. For empowering patients on visual privacy, it's not just about having a privacy curtain. It's being able to control whether or not it's open or closed from the bed or the recliner. It's about being able to control whether or not the door is left open or closed when people enter the room. So they want control of those things. For facilitating connection, you can think about having folding chairs in the room that hang on the wall that can fit in the space next to the bed that won't interfere with the clinical side where most of the work is being done, but where they can touch and connect to the patient. And then having independent access was really important. One aspect of that was in all of our rooms we had an electronic whiteboard where you could see the role and the name of everyone who's supposed to be in the room, including the housekeeping staff. So you felt secure that people who were coming in were supposed to be there and doing what they were supposed to do, and you knew who they were and what they were supposed to do. So they really liked that aspect. Obviously, in any study, you're going to have limitations. We did not have, even though we had a lot of people involved in our study, we did not have a large representation of different kinds of patients. So we might not have caught things about severe mobility challenges or maybe some special needs. Maybe morbidly obese patients would need a different kind of design for the hospital room or cognitive impairments. We did not have lighting, noise, or smells, and we also didn't focus on the materials in the room. So we were looking at the functionality. So we did not get into whether or not wood was better than vinyl or those sorts of things. And as Steve mentioned, we only had time with our design to show 2 of 5 rooms to each participant. So they only got to see 2 out of the 5. In conclusion, it's 3 C's and an A is one way to think about this. So comfort, connection, and access and control are the things that just kept coming up over and over again. And I know that Alan has been collecting together your comments and your questions, and I really look forward to discussing these findings with you and Steve as well. So thank you for the opportunity.
Thank you very much. There's the contact information for our 2 presenters. These will be available after the fact. And now, before we get to the Q&A session, I'd like to say thank you again to Herd Journal for providing free access to these articles we typically review. And if you would like to subscribe to the Herd Journal, go to www.herdjournal.com and use code HERD10 to receive 10% off the annual subscription. And now, it is your turn to ask questions of the authors. Please feel free to type in any questions you may have, and we'll try to get them answered. If we could, I'd like to start off with one, which is, was there anything that surprised you during the study about what patients wanted to see? There's really a lot of information that you gathered here.
Thank you very much for asking that question. I'll take a shot at it, and then we'll see if Steve has anything he wants to follow up with. The first is that it was interesting that there were these mixed results about visibility into the hallway from the bed. So from the patient's bed, I think we sort of came in thinking that there would be some trend about whether or not patients wanted to see in the hallway, and instead we saw very strong reactions on both sides. So there were people who wanted to look into the hallway almost for entertainment, just to see what the nursing staff was doing or who was coming or see what was happening. And then there were other people who just top priority was not to be visible, not to be on display, not to have people looking into their room and who really, really, really wanted that door closed, or almost not even to be seen by staff without having them come into the room. And then the other thing was the top priority being the controls. So we anticipated the lighting and the TV would be important, but we didn't really anticipate how important the blinds were, for example. So they wanted control of the blinds from the bed or the recliner so that they wouldn't have the sun shining in their face, or if someone came in to take an image from the imaging technology staff and they closed the blinds and then they forget to open them up again, they're stuck there, in kind of the dark. So they don't want to call somebody and have them help do those things. And then the temperature really mattered to the patients. And interestingly, the staff wanted parameters on that put. They did not want to give complete control to the patients. They were okay with giving some control to the patients within a range. I don't know, Steve, if you had anything else you wanted to add.
Yeah, that was a very strong response on the part of the staff when we were in that conflict resolution phase. Again, okay, a few degrees we could do with that, but we don't want to come into a room that's set at 90 degrees, and we understand that. So there could be limits on that, but giving people some control was really something that we heard a lot about. One of the other surprising things was we expected that they would want to see that staff sync and be able to see the clinical staff washing in, washing out. There was kind of a mixed response on that, less than we anticipated, which was interesting. That wasn't so important to them. They said, you know what, I can hear if they're washing their hands. I don't need to see it. So that wasn't so important. The other thing is we heard a lot about, I don't want to be disturbed when they come and take the trash out or they come and get the dirty linens and that kind of stuff. So having those kinds of things in close proximity to the door is real important. And, where you can do it, if you can have a pass-through kind of setup so that stuff can be emptied directly from the hall, so those, that staff doesn't even have to come in and remove those items. They can do it from the hallway. That was, when we mentioned that, they were all excited about that.
and that leads to another one, which is, what were the biggest, that Susan Bauer asked, and so what was the biggest point of divergence between what staff wanted and what patients wanted?
Wow, that's a great question. So one of the things that happened after this study was we went back to staff and showed them the modified 5 rooms. So there were 5 rooms that came out simply from a clinical perspective, what do you want to see, and also plumbers and engineers and all those people. From a hospital staff perspective, what do you want to see? We then got this feedback from the patients and their caregivers and modified the rooms to incorporate their suggestions. And then we went back to staff and showed them the modified rooms. And we definitely had some conflicts. And one of them was the family zone location. That family nook room, universally, patients and family members just hated being far away from the patient, stuck on the sleeper sofa where they have to kind of almost scream out to the patient, and there was a kind of uncomfortable turning for the patient's neck to talk to their family members. The staff loved it because it's out of the way, not going to interfere with their work, and they weren't interfered with as they were trying to get their things done. And even things like having a suitcase left out overnight from the family member that someone would trip over in the middle of the night was minimized if you had that family zone area in a corner. So that was a clear conflict that I think is solved probably by not having them far away or having some kind of support to go far away and come close to the patient, have both options. And then another one was that in some cases, these caregivers were acting almost like sitters. They were, helping family members to not fall or that sort of thing. And so what they were doing was taking the wheeled chairs from staff. In our initial phase one, we were learning that they were taking the nursing chairs with wheels. And our folding chairs did not have wheels on them because we thought that was a safety hazard for multiple reasons. And so there was an area where there was sort of a conflict about whether or not people sitting near the bed needed any kind of wheels. And then the third one I'll just mention is that these personal care assistants, PCAs, are the people who help with the baths and help the nurses support. They most of them had a strong reaction, not all, but most of them had a strong negative reaction to having the patients have all these controls about the blinds and the temperature and everything else, because they didn't want to solve it if it broke or if it was hard to understand. They didn't want to be tech support for the patients.
But at the same time, they did appreciate the fact that, well, this could lessen their workload because they wouldn't get
that's right.
Close the blinds. So
right, the blinds in particular,
Yeah.
Go ahead.
Yeah, I can imagine.
The key part there was, you got to make it such that the interface is pretty intuitive, and that people would be able to figure it out.
And having that universal controller. Right.
Right. But, such that you can read it and operate it. Easier said than done.
Judging by television remote controls, I'd have to agree with you.
Right, exactly. The other thing was the proximity of the bed to the door. A lot of staff wanted that bed as close to the door as possible, the door of the room, whereas patients wanted to be further from the door. We heard that pretty consistently. And it was interesting, at one point in one of those rooms where the bed was closer to the door, the patients just said, this isn't adequate at all. This is not going to work. And we moved the bed away from the door about 18 inches, and it really made a huge difference, and much more than you would have expected for, a foot and a half. But it really changed the characteristic of that space. I mean, I understand nurses want to be able to, get in, do what they need to do. They take a lot of steps in a day, and they're trying to, keep that under control. But on the other hand, it gets back to that privacy issue, being on display, feeling that we were hearing from the patient. So, that's a really challenging point.
And
conflict brings up.
Sorry.
Go ahead, please.
We did try to have a solution to that in our rooms, which we didn't have time to cover in detail. We had one of those peeking in windows as an option where staff could kind of peek in with a mini window just for that purpose. And part of the reason I think we didn't talk about it much is because the same reasons why patients didn't want to be on display were reasons why they would close that and not allow themselves to be on display even with that.
Mm-hmm. Yeah, they at least wanted to know when they were being looked at.
Right.
Yeah. That brings up a sort of philosophical question that Ed Huckabee asked is the patient room first and foremost personal space, or is it medical space, and which should drive priorities for design?
Well, our whole point in this project was really looking at it as it's a workplace. And, we have a lot of people who have to perform tasks that are oriented to improving the health of the patient. So we want those people to be able to work and operate, do whatever they do efficiently and effectively. So you got to argue it's more of the clinical space, but at the same time, that doesn't mean it shouldn't be comfortable, because as Emily said, the key thing we heard was patient comfort over and over again.
Yeah, I think that that even on the team, we had people who were sort of more oriented towards clinical and more oriented towards what does it mean to be supportive for patients and family members. And by team, I mean our own research team. And where I think all of us kind of drew the line was you can't bring in your TV from home and your painting from home and your Xbox from home and, all that kind of stuff. But on the other hand, the other place where we drew the line was the idea that you should discourage family members or too many family members from staying that long was kind of a mini theme that we were hearing from the staff. The problem with that is that the caregivers are shown to, improve healing, improve comfort, reduce length of stay, and actually reduce the workload of the staff. So that's where we drew the lines, was in not just actively, if you will, discouraging patients and family members from being comfortable. There was almost a feeling like the family was should not stick around, and so we had supports for overnight stays for one family member as something we just started with from the beginning.
Now, it was interesting, the patient's top priority seemed to be wanting to control their environment, more than just the TV, right? That universal remote control that you were talking about. Could you say a little bit more about that, where it comes from, what patients hope to get out of it, how it was going to interact with the staff? I know you mentioned that in some cases, if it's working properly and people can figure it out, it might reduce their workload, et cetera.
Yeah, no, that's a really good question. I think one of the things that came out of this is that it's very scary, particularly for some people with particular diseases, to have a 3 or 4 night stay in a hospital. That first night or two in particular are kind of scary. And so one of the ways to promote healing and promote a supportive environment was to reduce fear by enabling control. And people, in some cases, talked at extreme length about their lip balm not rolling off the tray table. When a staff member came in and moved the tray table really quickly and it fell on the floor and they couldn't get to it for a day or until somebody came back. So there was, it was sort of like, well, how important is the lip balm to your lips? It had nothing to do with that. It had everything to do with, control over your space, control over your things, that it's my thing and that I can get to it and that I'm an adult and I'm independent. So it was interesting how often these, if you will, little things, it wasn't just being able to call and just being able to charge your cell phone. It was also just having control over that in-bed environment. We actually ended up doing an entire exercise where we had Play-Doh and scissors and paper where we had people actually create their perfect in-bed environment because it got so fascinated by this whole tray table idea, which is in another paper.
But, back to, some of the control over things too, when we talk about storage of, personal belongings, we heard a fair amount about that. They didn't want the storage area behind them. They wanted to be able to see that storage area, to know that their stuff was secure. Not that much was necessarily going to happen, but it was a comforting thing to be able to see that their personal belongings were okay.
Yeah, and there seemed to be a real theme running through your paper with being able to see the personal belongings, be able to see who's coming into the room, being able to know who's supposed to be in there and when, and all of that. Can you talk a little bit about the role of sort of patient situational awareness and what they were trying to get out of that?
Sure. So there was a lot of discussion of the whiteboard when we did the clinical portion of the sort of phase 1, phase 2 research, where they talked about the whiteboard being what the staff updated to say who they were and how to contact me and when, various things were going to happen. But the patients were using the whiteboard. So the patients and family members would write on the whiteboards questions for when the clinical people came in, or they would write reminders to themselves, medication at 9 a.m. So there was actually patient use of the whiteboard. And if you didn't have glasses at the hospital, let's say you were brought to the hospital from some tragic situation where you couldn't grab your eyeglasses on the way, people talked about having the whiteboard and the clock be able to be made bigger electronically so that you wouldn't need your glasses while in bed. So that situational awareness, certainly on the clock, the window to being oriented to day and night, and then that whiteboard element.
Well, the other piece on that whiteboard is when we were talking about it in a little more detail, we heard a lot about, that would really be a whole lot better if it was electronic and you could have pictures of the staff members who were working with you that day. And, that situational awareness piece is, first of all, that could be updated continuously through the day as people are, shifts are starting and ending. And so, because we heard a lot about, the whiteboard's out of date. kind of thing. The person whose name's on there is my primary caregiver or nurse. They're not, they haven't been around for a day. So having that current information was real important. And as Emily mentioned earlier, we heard a lot about, people wanting to know who should be coming in their room. And it's like, yes, okay, you're the right person. I can see that, you're on your picture's on the board. You're the right person to be coming in here. And knowing who their caregivers were at any point in time.
And then as the patients got later in their stay, it became more and more important to kind of move from a cell phone to a laptop or some kind of computer-like support. So the cell phone was, answering questions and, telling family members what happened and that sort of thing. The laptop was, starting to essentially return to work. And then they would sort of move to the recliner area, and then they'd want a table or something like that. So another form of situation awareness was almost like an office-like environment for patients and their caregivers. Could be sort of in the family zone, but it could also simply be a small table that's movable in the room where you can put a laptop on it and start working on it.
Yeah. Speaking of movable furniture, I remember one of the questions that I had lined up wasn't the one I was going to ask next, but somebody was suggesting foldable chairs as a potential solution. Was that one of the things you looked at?
Yes. That was part of that whole stimulus process. As we said, look, there's 2 or 3 foldable chairs in this room because
right.
What we heard is, furniture moves, and the chairs would move, and by having, and we heard from a lot of the staff that chairs can be in the way. But being able to fold them up and move them out of the way, if you got to bring in that portable X-ray machine, or during rounds where there's several people coming in, that could be really nice. But having a lightweight foldable chair that you could pull over by the bed was really important to both the patients and their visitors. And it was also important to a lot of the caregivers as well, the social workers, for example. Wanted to be able to sit down and have an eye-level conversation with the patient. And the physicians said the same thing. They wanted to be able to have that, eye-level conversation. They didn't want to be standing over the person. You can imagine some of those conversations are not the kind of conversations you want to have, but you need to have. And you don't,
right.
And it just felt much more comfortable to be at eye level. But what they were talking about is, a lot of times, there's no chair available. But by having folding chairs, you could have, 3 or 4 in a room. They could be hanging on a hook on the wall kind of thing, so that they could always be there.
We found 3 types of visitors. This is in research that actually extended beyond what we presented today. There are people who need the folding chair. So the dietitian for an hour, or the clergy for an hour, or the short-term visitor from your work site. And then there's a medium-term visitor, which is either a caregiver or family member or somebody who is close to you in your family friend circle who stays for about 8 hours. And probably that folding chair would not be sufficient for them. They would probably want to have some kind of rest for their hands or more comfortable seating. And so a lot of them end up in the recliner if the patient's in bed, or maybe having something in between, like, for them. And then overnight you need that sofa. And we didn't discuss it in detail, but we talked about during the focus groups we had that the recliner could be extended during the night, so that you could sleep on a longer sofa at night and then have a shorter sofa during the day.
That's neat. It also seems like the foldable chairs might be a lot easier to clean if there were any kind of problem than a lot of the furniture that I've seen elsewhere.
Right.
Anna points out that foldable... Oh, sorry.
I'm sorry. I just want to say we did have housekeepers come in an earlier phase of the study, and they talked about needing to test all of the furniture in the room with their cleaning supplies. They talked about furniture looking like blood if it was red and it smeared. And so folding chairs didn't have that issue as well.
Anna points out that folding chairs and cabinets for supplies that are reachable from both the patient room and the hallway have been in Sweden for years now. So obviously some international learning that we could do as well. Another thing that I took away from no, that's a different one, is some of the rooms that you tested had hinged doors and some had sliding doors. And I thought the sliding doors idea was really neat. I was wondering, you didn't say a whole lot in the presentation about what patients thought of that. How did it work out?
With regards to the bathroom doors, everybody liked the sliding doors. Okay, staff and the patient. It was just everybody could visualize it was going to be a whole lot easier if you were the patient to be getting in that room, into the bathroom. Like if you had mobility limitations, you're using a walker, you get up to the sliding door, you push it to the side. That's a whole lot different than having a hinge door where you got to back up to open the door, then walk through, and then, turn around to swing it closed. That's a whole different process in itself. So if you were using it individually, and likewise, though, the staff were saying the same thing with regards to assisting patients through the bathroom. Mm-hmm. So definitely the bathroom door was preferred as a sliding door, pretty much across the board. And as far as the room door, what we heard, not so much from the patients, but more from the staff, was the sliding door just didn't take up the space in the room. And that allowed an easier, it allowed more functional entryway area that could be used for other things. Versus if you have a door that swings in, you're losing 4 feet of space right there.
Right.
Although I will say that we found, just as other people have found, with these things, you can't just say sliding doors recommended, because the actual design of the room, we had some that had swinging doors because it was so important to be able to have line of sight from the hallway to the patient bed. And one of the only ways to do that was to angle and sort of chop off a corner of the bathroom, and that didn't lend itself to a sliding door design.
Uh-huh.
Right.
Yeah, as always in healthcare, it's more complicated than that. And that sort of the gating space by changing to a sliding door for the entry to the room reminded me of a question that Ed Huckabee asked, and is it because maybe you use that space or counter space, were there any comments from patients regarding hospital staff piling supplies anywhere they can in the room without regard to the patient's personal space or without regard to the need to have space for family to use the room as designed?
Well, there's absolutely a yes to that. The biggest place where there was a sort of hooray from patients and family members were with regards to the bathroom counter space. So there apparently are bathrooms in hospitals where you can't have your soap and shampoo on a ledge. And you want to plug in your hairdryer and there's no place to put it. So we had designs that staff didn't seem to mind, that the patients and family members loved, with just having storage, even a small amount of storage, various storage elements in the bathroom. Outside the bathroom, it got a lot more complicated, where we specifically asked about shared staff-patient work surfaces, and pretty much that was a no-go from a staff perspective. And I saw that there was a question about having a pass-through with the clean and the soiled. We did have the pass-through. It was something the staff wanted. I don't know that the patients or family members cared either way about whether or not there's a pass-through. What's nice about the pass-through is you don't have people coming into the room unnecessarily, but I'm not sure the patients and family members really understood it. I don't know, Steve, if you had any other thoughts.
Yeah, I mean, I understand there's issues with that in some places, but where where you can have the pass through, that would certainly be a nice thing.
Okay. That takes care of like 3 different questions there. There are a couple about specific design choices and whether you ran into them. For instance, was there any discussion about preference for a 36 by 36 transfer type shower versus a 30 by 60 roll-in shower?
We didn't get to that level of detail with the shower.
Mm-hmm.
We said there's a shower here, and we said we did hear about, well, we want to make sure that I can get into the shower without tripping on something, and yes, that level we did hear about, but as far as the actual size, we didn't quite get there. We did hear a lot about having a hose kind of device that you could shower with, but one of the key features was the shower chair, or having the bench.
Uh-huh.
And everybody wanted that. And one of the things we heard from staff actually was those things, the shower chairs that are currently there, they move around. And then when you need it, you don't know where it is. And so then you got to go look for it. And then if it's in somebody else's room, before you take it out, you got to clean it. You got to bring it over. So what they really wanted to see was a permanent shower bench within each shower, so that they wouldn't have to go looking for that. And, the patients were all about having a place to sit as well, obviously.
Yeah.
Yeah, the shower was just one of those things where we kept saying, wow, there's got to be a technical solution for this, and then we kept discovering another reason why it couldn't be. Everyone agreed that the direct entry no-lib mattered, but then you had to worry about water coming out, so then maybe you have a sloped floor, but then that could be dangerous in itself. And so there was a whole lot about the shower that was discussed, and there was a lot about getting caregivers to help people through the bathroom door to get to the shower. And so I think we had a lot of questions about what to do about the shower situation. And for sure, I think at least where the staff felt was no family members ever allowed to use the showers in the room. So there seems to be kind of a line drawn where some family members really want to use just sort of everything in the room, and that line was one they didn't want to cross. Was that at least we as a design team decided we would not support designing family members taking showers in the patient's room.
So one last question. We've got a few built up here, but we are running out of time. This was a really neat study. If somebody wanted to take this sort of approach within their own design firm or within their healthcare organization, could you talk a little bit about how you went about it, how long they should expect this sort of approach to take, what exactly, at a high level, because we don't have much time, but what your methodological approach was?
Sure.
Well, go ahead.
No, go ahead. Yeah.
All right. Well, having a full-scale mock-up is I think really critical. Because we would start off with showing people like a floor plan, and they didn't get it. It was like when they would walk in and then see the full-scale mock-up, you could see the light bulb went on. It's like, oh, I now I understand what you were trying to show me. So that, like those floor plan diagrams that I was showing, a lot of people had trouble with those. We would introduce each room with that floor plan just to kind of get them oriented before they walked in. But, I'm not sure that really got them very far. So I think people have a real hard time viewing that stuff. Having a full-scale mock-up, having something that doesn't look permanent. Like, if you have a full-scale mock-up, but it's all made of wood and it looks nice, people don't feel like they could say, oh, this isn't in the right place for me. By having everything Velcro, I think we were able to really get a lot of input as far as, oh, this is where it could be. And in fact, while we had these spaces pretty much set up for the patients and visitors that came in, there were many times they said, well, what if we move this whiteboard over here? Or, we say, okay, do that. And they could do it and stick it up over there, and they would talk about how that was better for them. Or, so by being able to have things movable, I think that's a real key feature.
And then I would just build on that by saying it's very important to have the stuff that makes the room look messy. So we had a patient's suitcase, a patient's laptop, a glass, the cell phone, the iPad. So it's easy to evaluate a room that looks clean. We actually purposely brought in, even though they were faked or whatever, flowers and gift cards. And I think it's easy to forget all that stuff when you're designing if it's not in there. And we had somebody in the bed pretending to be the patient. So you didn't forget about the patient.
That's fantastic.
The place looks a lot different when there's actual stuff in there, and that becomes real important when you start saying, well, wait a minute, where's the patient going to put their suitcase? Where's the patient going to put their flowers, their cards, all of that stuff? Having that represented was real important because it led to those kinds of discussions.
Fantastic. I mean, we could go on for another hour here, but I'm afraid we're out of time. Thank you both very much for this really interesting and thoughtful look at how supportive design can increase patient satisfaction and improve the healing process in medical surge rooms. This concludes our event. We'll leave the webinar open for another 30 minutes so you can download the EDAC and AIA CEU forms. Thanks again, everyone, for joining us, and have a great day.